Good afternoon, everyone. You are welcome to the monthly webinar organized by Cardiocare Multispecialty Hospital. Cardiocare Multispecialty Hospital is located at number 5 Isa Street, opposite Indofia, off Donokofia Street, area 11, Gariki. So who are we? We are a support and a reference hospital for internal and cardiovascular medicine specialties and subspecialties. We propagate healthcare delivery and training. Our aim is to reverse medical tourism. Cardiocare Multispecialty Hospital is a flagship specialty hospital of Limi Hospital, originally founded in 1982, opened July 2016. Our topic today is evaluation and management of palpitation. My name is Dr. Taiwo, FE. Now with me is
Dr. Ikem Catherine. So as part of our objectives for this presentation today, we would like to understand the definition of palpitation and also want to learn about the possible etiologies of palpitation, how to assess the patient who presents with palpitation, and also how to manage cases of palpitation.
Okay, thank you, Dr. Catherine. By way of introduction, palpitation is common and has non-specific symptoms, often benign in origin, but also the most common symptoms of a life-threatening arrhythmia. This sensation can be either intermittent or sustained, and either regular or irregular. It's good to note that palpitation does not mean heart disease, and the degree of palpitation does not equal the severity of heart disease. It is an intermittent or sustained awareness of the heartbeat, often described by the patient as thumping, pounding, or faltering sensation in the chest. I'm sure a lot of us have come across this presentation in our various clinical practice. A cardiac arrhythmia is defined as disturbance of the electrical rhythm of the heart. While palpitations and arrhythmia are often associated with each other, they are not the same. All palpitations are no arrhythmias, and many arrhythmias do not palpitate. So various definition and description by patients and various textbooks defined as rapid pulsation, abnormally rapid or irregular beating of the heart, perception of a skip beat or rapid fluttering in the chest, pounding sensation in the chest or neck, uncomfortable awareness of one's own heartbeat, or undue awareness of heart action.
So palpitation makes up about 16% of outpatient department visits, and it represents about 5.8 in every 1,000 visits to the emergency room, with an admission rate of about 25%. So it's the third commonest complaint in a cardiology clinic after chest pain and shortness of breath. So for 3% of cardiac origin, and in a study done among 190 people, it was the chief complaint of palpitation. It has been found that it's more reported cases is found among females, and it can occur at any age, but it's more common among middle-aged and elderly patients.
Palpitation is due to alteration in heart rate, e.g. sinus tachycardia and bradycardia, alteration in heart rhythm, e.g., for example, atrial fibrillation, atrial flutter, alteration of subjective assessment, maybe in anxiety state, depression state, augmentation of myocardial contraction in anxiety state, and some drugs. So we have physiological augmentation and pathological augmentation. Physical augmentation is seen in cases of exercise, in where the heart contracts more to meet up the demand of the body. Caffeine, tea, alcohol, aminophylline, and ephedrine. All these are stimulants. They tend to increase the myocardial contractility, while pathological augmentation occurs in setting of ventricular hypertrophy from hypertension, valve disease, thyrotoxicosis, anemia, fever, and neuroglycopenic symptoms of hypoglycemia. So I want to briefly talk about the pathophysiology of arrhythmia generally. We know the cardiac cycle is usually initiated by electrical discharge of the SA node. So the atrial and ventricle then activates sequentially as electrical polarization passes through this specialized conducting tissue. The sinus node acts as a pacemaker, and its treating rate is regulated by the autonomic nervous system. Vagal activity decreases heart rate, and sympathetic activity increases heart rate through cardiac sympathetic nerve and circulating catecholamines. There are three main mechanisms of tachycardia or arrhythmia. So we have increased automaticity, re-entry, and triggered activity. The re-entry is the commonest pathophysiology of most arrhythmias, vis-a-vis the pathophysiology of avinodal renal tachycardia, supraventricular tachycardia, most VTs, atrial fibrillation, and atrial flutter. Bradycardia may be due to reduced automaticity of the SA node or abnormality of conduction through the AP node. So what happens in re-entry is there is a loop of electrical activities run around functional obstacle of impulse, in which electrical activity keep on rotating around it and then to excite already excited tissue. So that is the pathophysiology. Most arrhythmias are due to re-entry, and others are increased automaticity and triggered activity.
So the causes of palpitation can be of various origin, can be of cardiac origin, which we see in about 43% of cases. It could be as a result of a psychiatric disorder. You see that in about 31% of cases. It could be miscellaneous, and it could also be idiopathic. So for the cardiac origin, it could be as a result of a structural heart disease or a rhythm disorder or a mixture of both. And this makes up the commonest cause of palpitation, because we see this in about 43% of cases. So there are also some predictors, independent predictors of cardiac etiology or palpitation, and this includes the male sex.
Okay. Independent predictors of cardiac etiology or palpitation, meaning that if you see this in this setting, you are likely to say that the etiology of palpitation is of cardiac origin. Male sex, when patient describe an irregular heartbeat, history of heart disease, like history of ischemic heart disease, rheumatic heart disease, valvular disease, and if the event duration is greater than 5 minutes. For one predictor, 26% chance of being cardiac etiology, two predictors, 48% of being cardiac etiology, and three predictors, 71% of being cardiac origin. So we have the cardiac causes, which account for about 43%. We have rhythm disorders and non-arrhythmic cardiac causes. For the rhythm disorders, premature contractions, which include premature atrial complexes, premature ventricular complexes, atrial fibrillation, atrial flutter, supraventricular tachycardia, ventricular tachycardia, Wolff-Parkinson-White syndrome, ectopics, sixth sinus syndrome, bardiarrhythmias. While the non-arrhythmic cardiac causes include systemic hypertension, mitral valve prolapse, left ventricular aortic obstruction, case of atrial stenosis, apostrophic cardiomyopathy, aortic insufficiency, right ventricular dysfunction in the setting of pulmonary embolism, atrial septal defect, ventricular septal defect, atrial myxoma, myocarditis, and pericarditis.
So for the psychiatric causes of palpitation, you want to be aware of the possibility that patient might be having a panic attack, could have anxiety, they could also be depressed or have somatization. So patients with psychiatric causes of palpitation, they more commonly report the emergency, they have more emergency room visits, they have a longer duration of the palpitation, so sometimes greater than 15 minutes. Then it's usually seen in the younger age group, and then they have multiplicity of symptoms. They have other accompanying symptoms coupled with the palpitation.
So we have the miscellaneous causes, which account for 10%. In hyperkinetic circulatory states, anemia, fever, thyrotoxicosis, hyperglycemia, fibrinocytoma. Then drugs, aminophylline, tyrosine, tricyclic antidepressant, digitalis, and others, caffeine, cocaine, tobacco, ethanol, and vitamins. Other causes include spontaneous skeletal muscle contraction of the chest wall in case of fasciculation, twitching, and this is seen in setting of maybe depression and all. Then systemic mastocytosis. Systemic mastocytosis is a situation whereby there is abnormal proliferation of mast cells in the organ, especially in the bone marrow, in which patients present with anaphylactic reaction, they present with chest pain, palpitation, and even difficulty in breathing. Other physiological causes, exertion, excitement, pregnancy, and then also neurocirculatory asthenia, or Costa syndrome, Euphor syndrome, or Sodia's heart. This was first reported by James Da Costa. It was found to be initially a heart condition, but later it was found to be of multiple etiology, not related to cardiac. What happened, it was first reported among the soldiers. That was why it was named as soldiers' hearts. They present with exertional dyspnea, they present with chest pain, palpitation, and all. And this has been reported in American Civil War and other war lines. Also, we have esophageal attacks, panic anxiety disorder. Panic anxiety disorder and cardiac arrhythmias are not mutually exclusive. These two coexist. So it's always good to know that as physicians, as clinicians, we should always complete a full cardiac evaluation in patient presenting with palpitation.
Okay, so in evaluating the patient, the principles of our objective would be to determine if the symptom of palpitation is life-threatening. We've seen that life-threatening arrhythmias most times present with palpitation, but also let's remember that all palpitations are not as a result of an arrhythmias. They are not arrhythmias, and many arrhythmias do not palpitate. So we want to, first of all, determine if the symptom is caused by a life-threatening etiology. Then we also want to reduce possible risk other than the direct effect of the arrhythmias. For example, in the patients with atrial fibrillation, we want to start up treatment to help reduce the chances that they could have a stroke. Then we also want to know, part of the objective would be to find out if the patient requires hospitalization urgently, and also if specialist consultation is required and how urgently it is needed.
So the approach in the evaluation of patients with palpitation include a focus history about how the palpitation started, what are the precipitants, any previous history in the past, drug history, then relevant physical examination and diagnostic evaluation. So still talking about the history, we want to know the character of the palpitation, the mode of onset, mode of termination, precipitant, associated symptoms. If this palpitation released with vagal maneuver, such as in case of supraventricular tachycardia, in their family history of such. So in our heart patient department, history and physical examination is key. But why in emergency departments? Of course, to resuscitate the patient is the first goal, while history and full examination can come after stabilization. So ABC of resuscitation, stabilization, patient with IV, oxygen, patients on cardiac monitor, ECG, cardiac enzyme. So if patient presents to the emergency department, stabilization first, and then history and full examination after stabilization.
So in history taking for a patient to present with palpitation, you're very concerned about the age of onset. So you want to find out, is it true palpitation or other symptoms stimulating it? So do they have chest discomfort? Do they have dyspnea? because this can also be confused as palpitation. So you want to be very clear if they are actually having palpitation or if they're having a chest discomfort or some difficulty breathing. Then also you want to also note that it could be physiological from exertion, such as after running, after sexual activity. Then also you want to know if it's is it affected by activities? Does it wake the patient up from sleep? Then also note other associated symptoms such as lightheadedness, any history of sweating, diaphoresis, of nausea, of fainting could also be of importance.
So it's also good to ask whether it's paroxysmal or persistent. So if this palpitation is paroxysmal, so what is the mode of onset and offset? So for abrupts onset, plus or minus abrupt termination, you'll be thinking more of SVT, supraventricular tachycardia, ventricular tachycardia, or sick sinus syndrome. But if it's of gradual onset, plus or minus gradual termination, this is usually other benign causes, such as sinus tachycardia. Then any relief with vagal maneuvers. Vagal maneuvers is usually known for SVT. The idea is for release of for activation of parasympathetic nervous system that will lower the heart rate. Then does this palpitation will worsen at night? If this palpitation will worsen at night, then usually ectopic beat should be considered. They're also going by the character. Is it flip-flopping, meaning that it starts and stops? Is there a feeling, is there a sensation of missing a beat? Is there some sensation of thumping the heart? So if all these are present, PVCs may be the first to be considered. Then rapid, regular, or racing or fluctuating in the chest, think of sinus tachycardia, SVT, and VT. Rapid, irregular, fluctuating, and jumping about. Think of sustained VT, supraventricular tachycardia. Then if this rapid, fluctuating or jumping about is regular, think of AV nodal reentrant tachycardia, which is the commonest supraventricular tachycardia. And if it's regular, think of atrial fibrillation or tachycardia with variable block. Then if the patient reports pounding in the chest, we consider hyperdynamic circulation. So this is just a table showing us what to consider when patient presents to us. Okay, the presentation, the complaint of heart misses and thumps. We think of ectopic beats like PVCs, PACs. Water stress, we think of ectopic beats. Very fast, regular, think of supraventricular tachycardia, ventricular tachycardia. If also of sudden onset and sudden termination, think of SVT and VT. Offset with vagal maneuver, as I've said earlier, vagal maneuver to increase parasympathetic discharge to bring down the heart rate. So you think of SVT. Then if it's fast and irregular, atrial fibrillation, flutter, variable block should be considered. Then forceful and regular, not fast. You know, patient is just being aware of sinus rhythm, maybe in setting of anxiety. If there's severe dizziness or syncope, VT should be top on the list, and then bradyarrhythmias. And if patient has pre-existing heart failure or pre-existing cardiac disease, we may think of VT. So what about the radiation? Does this palpitation relate to the neck? If the palpitation relates to the neck, AV nodal tachycardia are the commonest cause of the palpitation related to the neck. AV nodal tachycardia include AV nodal reentrant tachycardia and AV reentrant tachycardia. What happens in this setting is there is simultaneous contraction of both atria and ventricle, and this causes reflux of blood into the superior vena cava. So this results in pounding sensation in the neck, and this is called frog sign. It's called the frog sign. So if we see a patient in the emergency with palpitation, with the pounding on the neck, so we think of AV nodal reentrant tachycardia. Often, a finding of canal AV in JPP can occur, and this as a result of the right atria contracting against a closed tricuspid valve. Other associated symptoms include low cardiac output in arrhythmias. That this is a result of the because of the rapid heart rate, the ventricular filling is impaired, So patient can present with symptoms of low cardiac output, syncope. Patient can also present with bradycardia. Then also hypoglycemia also can also present with syncope. Then it's good to know that if there is dyspnea before palpitation, we're thinking of acute MI, P of valvular dysfunction, and dyspnea after palpitation, maybe heart failure due to arrhythmias, VT, chest pain before palpitation, acute MI or P, and chest pain after palpitation, maybe an angina due to palpitation in case of aortic stenosis and mitral valve prolapse. Other associated symptoms include polyuria. This can be seen in the setting of atrial fibrillation falter, supraventricular tachycardia. This is as a result of release of atrial natriuretic peptide. What happens is that is in the setting of atrial fibrillation and falter or supraventricular tachycardia, there is increase in atrial wall. The stretch in atrial wall results into release of atrial natriuretic peptide, and this causes sodium water excretion, and also this atrial natriuretic peptide inhibits the ADH, it's antidiuretic hormone. So patients tend to have polyuria. There's sweating also. In case of acute MI, there can be sweating. In case of hypoglycemia, sweating can be seen. In anxiety, sweating can be seen. In thyroid toxicosis, pictures of hyperthyroidism, sweating can also occur. In diarrhea, hypokalemia, and also in thyroid toxicosis. Patient presenting with melena, heavy menstrual bleeding, so we can see anemia in them. Heat intolerance, weight loss, increased appetite, child sources can be the cause here.
So other important history would include finding out if the patient has had a pre-existing heart condition, such as if they had ischemic heart disease, if they've had a previous MI in the past, if they've had a valvular disease, or if they have cardiomyopathy, or they are a known heart failure patient. So also you want to find out if this patient is pregnant, if they are aware they have hyperthyroidism. Anemia can also be a cause of palpitation. Then also if they have fever or they are asthmatic. Then you also want to note any recent history of intake of stimulants such as caffeine, alcohol consumption, or a family history of sudden cardiac death. Then you want to also know if the palpitation is relieved, if it's relieved by Valsalva maneuver. This is very significant for supraventricular tachycardia. Then you also want to note any past or family history of similar complaints. So the key feature of physical examination will be to help refute the presence of arrhythmia as a cause of palpitation, as well as its adverse hemodynamic consequences. So we would want to, in examining this patient, take note of the patient's vital sign, want to assess the jugular venous pressure and pulse of this patient, and then also auscultate the chest and the precordium. So you want to, in general examination, you want to check if this patient is pale, because we know that anemia can be a possible cause of palpitation. Then also, because we also know that thyroid toxicosis can be a cause, we want to check for anterior neck swelling and check if patient has exophthalmos, if they have fine tremors. Then we also want to check if they have murmurs, listen for murmurs, and others could include third heart sounds, as you can see in heart failure, a patient who has heart failure, fourth heart sound in a patient with left ventricular hypertrophy, then a loud P2 component of the second heart sound. You can see that in a patient who has pulmonary embolism, then bivasal pinwheels in heart failure, then calf tenderness in the patient who possibly has a deep venous thrombosis. So the general appearance of these patients will be noted. So do they look pale? Are they sweaty? Do they look anxious? Let's take note of that. You want to take note of the patient's blood pressure also. Then all this discussed already, neck examination for jugular venous distension, then raise JVP, No, that then also for pallor and neck examination and examine for fine tremors and so by way of investigation, we want to order for a 12-lead ECG for this patient. We also want to do alter ECG, so 24 hours to 96 hours ECG monitoring for this patient. Then you want to check their blood sugar profile because we know that hypoglycemia can be a side effect of hypoglycemia can cause palpitation, and you want to make sure that this patient is not diabetic or on any any hypoglycemic agents. Thank you. Then we also want to do a serum electrolyte test. So mostly we want to be concerned with the patient's serum calcium, the magnesium and phosphate profile. We also want to do a thyroid function test to rule out or rule in if this patient has possibly has thyroid dysfunction, they have thyroid toxicosis.
So thyroid function tests to rule out thyroid toxicosis, other cardiac markers, we are suspecting myocardial infarction, D-dimer, we are suspecting PE, and echocardiography to rule out structural disease, and treadmill exercise testing for palpitation precipitated by exercise. Okay, so checking if we found all this in on the ECG, so what are the implications? What are the considerations? So if we requested for ECG for patients and then we are seeing pre-excitation or delta wave, consider Wolff Parkinson-White syndrome or AV reentrant tachycardia. If on ECG we are seeing left atrial enlargement, frequent PVCs, frequent PACs and sign of tachycardia, we may consider likely atrial fibrillation. If you see LVH on ECG, so we think so this might imply that patient may have atrial fibrillation, ventricular tachycardia. So further workup will be needed. Frequent PVCs, we think of ventricular tachycardia. If you see key waves, it could be ischemic disease or VT, and there are widespread T wave inversion across cordial leads. If you think of hypertrophic cardiomyopathy, especially the apical form of hypertrophic cardiomyopathy, so risk of atrial fibrillation and ventricular tachycardia is higher. Then we see long or short QT interval or Brugada pattern in which we see co-ST segments elevation up to 2 mm in the precordial leads with T-wave inversion. So think of genetic causes, genetic arrhythmia syndrome, and the risk of sudden cardiac death is high. Then inverted T-wave or epsilon wave across right precordial lead. This is a typical of adrenogenic right ventricular cardiomyopathy in which there is valvopathy replacement of the myocardial tissue. So risk of sudden cardiac death is also high. Okay, so talk about further investigating our patients. We do ambulatory ECG monitoring. So when do we ask for this ones? First of all, we do 12-lead ECG for patients with palpitation. All patients presenting with palpitation have ECG done. So the advantage of the 12-lead ECG is that it's readily available, it's inexpensive. And then the 24 to 48-hour Holter monitor. This is necessary for patients with daily to every second day symptoms frequency. And also usually available, we have it here in our center. It does not require any activation, can detect asymptomatic arrhythmia, and no yield than for daily arrhythmias. Then we have event recorder, events or loop recorder that range for 1 to 4 weeks. So this frequent symptom, symptoms frequency, if it's weekly to monthly, so patient can be put on loop or event recorder. And increase it and cost-effective versus Holter. Most units only record ECG patient triggered, though not useful for asymptomatic arrhythmia or syncope. Patient discomfort for long-term monitoring, patient can record discomfort. Then this implantable loop recorder, can even record patient symptoms for up to 3 to 5 years. It has a very high yield, long-term monitoring, approximately 3 years, and can be triggered, patient-triggered episodes. Not available in our center, but we have it here in our center here, Cardiocare Multi-Speciality Hospital. And it's currently only approved for diagnosis of cryptogenic stroke. Then talking about the handheld ECG. Handheld ECG is also okay. Symptoms of frequency can be month to year. Also high yield, permanently available to patients. It's just that cost to patients, time for activation of device before arrhythmia termination. So we can send in your patient to us with palpitation ranging from days to weeks to months to years. We can treat them. Okay, so this is an extended Holter monitoring. We can see this is a device put in the patient's pocket here with the electrodes. It's helpful palpitation is paroxysmal and occurs on a regular basis. So the electrodes with a monitoring device are attached to the patient for a 1 to 14 days. This is an extended Holter monitor as against this 24-hour monitoring. So patient is asked to continue and record his activities in diary, and then the reading strips are then analyzed. So we have the external and internal loop recorder. Like I said, we have it in our center. It's placed, just a minor procedure. It's placed under subcutaneous tissue of the patient, the upper part of the chest. So you can see it. We have it here. Can record patient symptoms for up to 3 to 5 years. Then we have the external one here. Okay, so this is an example of chest X-ray of patient with implantable loop recorder. It's a small device that is planted under the skin. Every palpitation are paroxysmal, but not very regular to be captured by Holter. We had a patient like that, we placed on 24-hour, 48-hour monitor. We didn't pick anything, but it was when we placed the patient on implantable loop recorder that we were able to get the patient symptoms, the patient arrhythmia. And like I said earlier, it's been recommended for in cases of cryptogenic stroke. So it records and stores heart activity as ECG and battery life over several years. Patients are instructed to activate the recorder whenever palpitations are felt and visit the physician. So like I said, we have it in our center. So you can refer your patient to us. We help you put the loop recorder there, and then we make the diagnosis of the arrhythmia for the patient. Okay, so what are the common arrhythmias that we have? Common arrhythmia encounter in our day-to-day practice. You can see here atrial fibrillation, variable atrial interval, atrial flutter with sawtooth appearance. Then this is SVT. You can see the P wave embedded in T wave. The heart rate is usually between 150 to 220. So this is SVT. Then we have ventricular tachycardia. These are the commonest arrhythmias seen in our day-to-day practice. So management.
So in managing a patient with palpitation, you want to seriously consider the possibility of them having a life-threatening arrhythmia or a structural cardiac condition, since that's the major or the constitutes the most cause for presentations with palpitations. So if the patient is sufficiently feel like they're being troubled and they have occasional benign atrial or ventricular premature contractions, you can place this patient on beta blockers. And then if the patient gives a history whereby you find that they use stimulants such as alcohol, tobacco, or illicit drug, you have to cancel the patient on abstaining from search, and while others that might have been caused by pharmacological therapies, such as drugs that are supposed to be therapeutic, consider switching them to alternative therapies as appropriate. Then for patients who have psychiatric causes of palpitation, they might benefit from cognitive behavioral therapy or from pharmacotherapy, as the case may be. Then if it's as a result of an arrhythmia, you should treat with antiarrhythmic drugs and consider electric cardioversion. Then counsel the patient on lifestyle modifications and management of other comorbid conditions.
So it's good to know that palpitation incited by alcohol, tobacco, illicit drug need to be managed by abstention. I've seen some patients now in my practice that they will say that after taking alcohol, that's when they want palpitation. So in such patients, just tell them that you need to stop. So we found out that by the time they stop, their palpitation will disappear. So history taking is key in the management of this palpitation. Then for common arrhythmia, like for atrial fibrillation, we can consider beta blocker, amiodarone, class 1C drug like lecanemab, digoxin, and catheter ablation, and this cardioversion. For atrial flutter, beta blocker, amiodarone, digoxin can be considered. For VTs, we can do this cardioversion, amiodarone, implantable cardioverter, and for SVTs, carotid sinus pressure, vascular maneuvers, adenosine can be given, and cardioversion in severe cases. For Parkinson White and AV reentrant tachycardia, we can give carotid sinus stimulation, IV adenosine, and catheter ablation. For atopics, can consider beta blocker. Okay, so what are the common antiarrhythmic drugs? We know the class 1 to 4, and others. Class 1, just to remind us, class 1 drugs, class 2, class 3, class 4, and others. Class 1 drugs are the disopyramide, the lidocaine, mesillectin, flecainide, propafenone. While class 2 are the beta blockers, atenolol, bisoprolol, metoprolol. Class 3 is amiodarone, luradenone, sotalol. Class 4, verapamil. Others include atropine, adenosine, digoxin. So what are the main uses here? For the class 1, main uses, treatment and short-term prevention of VTVF, prevention of for lecanemab, prevention and treatment of atrial and ventricular tachyarrhythmias. For class 3, serious or resistant atrial and ventricular tachyarrhythmias. And class 4, treatment of SVT and control of AF. These are the doses here. I don't want to bore us. Then they have important side effects to look for. Let me talk about the side effects of the amiodarone. Yeah, can have photosensitivity, skin discoloration, corneal deposit, thyroid dysfunction. It can cause hypothyroidism, hyperthyroidism, among others. Okay, so this is the summary of the schema representing the summary of what we are talking about. Okay, patient present to us. History and examination is key. Pallor, palpitation, pallor, diaphoresis, sweating, and syncope, history of previous drugs, history of alcohol injection, and all. Then examination, we look for pallor, we look for JVP, examine the chest. Then we ask for ECG. So then we proceed to echocardiogram. If cardiovascular symptoms or risk factors are present, vis-a-vis dyspnea, non-exertion, autopnea, PND, symptoms of heart failure, and then patient has risk factor like ischemic heart disease, valvular disease, then we ask for Holter monitor for frequent palpitation. Now we proceed to diagnosis confirm. When after doing the echo reveals a structurally normal heart and normal ECG. So we go ahead and manage as appropriate. Okay, manage as appropriate, but we consider referral if the palpitation is still sustained and then maybe patient has warning signs of diaphoresis, you can refer, you can refer. Then if after doing echo and ECG, everything diagnosis confirmed and structurally normal heart, normal ECG, and if there is no normal heart, so we consider cardiology consult to send your patient to us. The patient can benefit from EP study. Then unexplained palpitation, okay, structural heart disease, abnormal ECG. Patient will benefit from cardiologist specialty and EP study, and then structurally normal heart ECG. Okay, referral, you can refer if frequent and distressing. But if structurally normal heart ECG, no further management is required if it's infrequent and non-distressing. So for this, infrequent and non-distressing, can just reassure patients and then cancel off on lifestyle modification. So we have made this algorithm for better understanding of palpitation in our center, and I know it will benefit us as we are looking at it. Okay, take for example, patient with palpitation. We have talked about taking history, performing physical examination, what to ask in the history, the character, the precipitants, does it wake patient off, is it flip-flop? Then perform physical examination, is there pallor, is there diaphoresis, is there proptosis, to rule out underlying causes, and then you get a 12-lead ECG. So after that, you proceed to full blood count to rule out anemia, chemistry, to look at calcium, magnesium, thyroid function test, to rule out thyroiditis or thyroid dysfunction, and screen for drugs where appropriate. Then we proceed to echocardiography and on or alter if structural heart disease is present. Now look at 4A. Extra cardiac cause diagnosed. Okay, then look at 4B, structural disease confirmed or suspected. Refer to Cardiocare, other cardiologists, but you refer to us, and I'm sure you'll be glad you did. Structural disease confirmed or suspected, refer to Cardiocare hospital. Then we proceed to alter monitor if daily palpitation. So after the alter monitor, we can monitor the event for 2 weeks if palpitation are less than daily. Then in the alter, palpitation during normal sinus reading, 6A. 6B, if on the alter we pick premature ventricular contractions, Lang grade 1 to 2. Lang grade 1 to 2 means Lang grade 1 is infrequent PVCs less than 30 per hour, while grade 2 is frequent PVCs greater than 30 per hour. So if patient fall in Lang grade 2, and then the system is distressed, we can consider low dose beta blocker, otherwise we can reassure patient. But if patient fall into Lang grade 3 is when the PVCs are multifocal, grade 4 when it's couplet, or grade 4A when it's couplet, or grade 4B when it's sabos, when that's not sustained VT. So patients will benefit from arrhythmic drug. Now, non-ventricular arrhythmia, you treat. Ventricular arrhythmia, you treat. So 7B, reassure patients except you are considering structural disease that indicates treatment. So 7A, you treat anxiety, thyroid issue as appropriate. And number 8, you may consider device therapy. I'm glad to announce to you that we implant devices here, and we have recorded a lot of cases that patients are forever grateful to Cardiocare. We can consider device therapy, especially in cases of heart failure patients that have been on guideline medical directed therapy for 3 to 6 months without improvement in their symptoms, without improvement in their ejection fraction. And then if they reach, and then they have risk of sudden cardiac death. If the risk of cardiac death is significant in them, especially with heart failure, OCU. So refer to Cardiocare for device implantation program. And also for patients that have their device already, you can send to us to reprogram or to do interrogation also for them. Yes. do that here. So referral, when do we refer? Patient with frequent symptoms of persistent arrhythmia, you refer such patients. Significant associated symptom, simple breathlessness, patients must be referred for cardiologist review. For this kind of, for this group of patients, they should not be reassured, but they should benefit from cardiology review and FDP studies. Family history of recurrent scope of studying them also. Then significant ECG or echo abnormality, you are seeing short PR interval, delta wave, T-wave abnormality, a delta wave in setting of Wolf-Parkinson-White, T-wave abnormality, maybe in MI, Q waves in MI, long QT interval, short QT interval, Brugada pattern, like I said, STS segment elevation, post-getting ST segment elevation, V1 to V3, with T-wave inversion, repolarization changes, you should refer such patients. Okay, we can assure reassurance after excluding fatal causes, then lifetime modification, correction of comorbidities, anxiolytics in case of the psychiatric causes, anxiety, depression, and then beta blockers, then anti-arrhythmic drugs, and electric cardioversion, cases of atrial fibrillation, flutter, VT, and psychiatric cause of palpitation may benefit from cognitive or pharmacotherapies. So in conclusion, palpitations are non-specific symptoms with broad differential diagnosis. Palpitations are not a reliable indicator of a significant arrhythmia, but palpitation in a patient with structural heart disease or an abnormal ECG may be a sign of serious problem and warrants investigation. A thorough history, a thorough physical examination, along with ECG, laboratory findings are essential for diagnosis, focusing on the circumstances, associated symptoms, and potential triggers. Patients with dizziness, syncope, shortness of breath, or chest pain will warrant further investigation of serious underlying conditions. So these are my references. Thank you. Thank you all. Thank you. Thank you. You can send in your questions. I can see Maria Ahmed raise a hand up. Send in your questions. You are saying plenty things already. So while we wait for you to send in your questions, I want to also let you know about our health walk tomorrow at around 7 a.m. at the Limi CBD branch. Yes, please join us. We're walking in commemoration of World Heart Day, which will be on Monday, but the health walk will be tomorrow. So please join us by 7 a.m. tomorrow morning at Limi CBD headquarters.
So thank you. Please send in your questions, any clarifications, just let us know. And also, you can also tune in into our media rounds on Monday and on Wednesday, yes. Also as part of our activities for the World Heart Day. So thank you very much. Send in your questions and clarifications.
So we're waiting for more questions. Thank you, Medino Nkata, for your question. Palpitation, the question reads, palpitation associated with physiological changes in pregnancy. If it's pertinent, what's the approach to the management? Most people, it's a physiological cause. Most people with palpitation in pregnancy do not really require treatment. So for that, like I said, such patients should have ECG done. Are there other associated symptoms like dizziness, like chest pain, and all those ones are not there? Then you should check the PCV of the patient. If there is anemia, the patient should stay hydrated, should manage stress and all. So if all these things are done, I'm sure the palpitation will abate. But most people with palpitation in pregnancy do not really require treatment. Thank you. More questions? So I want to use this opportunity to tell us about heart failure support group in this hospital. We have heart failure support group for people living with heart failure. It's a form of community for them to create a friendliness environment, create a community. They meet with other heart failure patients. We give educational topics. We discuss them about heart failure and its management, about their diets, about their drugs, how to check their vital signs and all. So you can send in your patient number to us. We include them in the support group. The support group usually first Saturday of every month. The next one is coming up by 6th of October, right? 4th of October. That's next week Saturday. So you can send in your patient to us. Thank you. More questions, please. Answers. More questions? So more questions, or should we start to ask questions? More questions. So refer your guests to us. In our hospital, our patients are so dear to us. We don't call them patients, we call them guests. So sometimes if we talk, we use the word guest and patient interchangeably. So it's the same thing for us here in Cardiocare. So our patients are our guests.
Okay, so also as part of the activities we have planned out for the World Heart Day on Monday, we're having free medical checks at Grand Square. So from 3 p.m. on Monday, you can come in to have your vitals checked, and the results of whatsoever investigations that will be done for you on that day will be printed, and if you would need further review, either by a cardiologist or whichever specialty it be, can then be referred to see one. So join us at Grand Square on Monday by 3 p.m. Yeah, thank you. Please send in your questions and clarifications.
So thank you so much for joining in. My name is James Emmanuel. I'm the head of corporate relations of the hospital. So we are open to referrals. As you can see on your screen, you can refer to us. When you have cases that our services are needed, you can reach out to us. So this webinar is hosted by Cardiocare Multi-Specialty Hospital. It happens every last Friday of each month. Do well to join us next month. And I hope you had a great time. And thank you so much. You have a wonderful evening and stay blessed. Thank you.